Imagine waking up from a massive surgery. The overhead lights are super bright, the anesthesia is finally wearing off, and the surgeon comes into your room with this huge smile.
Right, they put the x-rays up on the screen,
Yeah.
and the bone work is just flawless.
Exactly. I mean, the metal implants are beautifully aligned, perfectly seated in the pelvis. It is a total mechanical masterpiece.
But then the physical therapist comes in and asks you to wiggle your toes.
Yeah, and you can't. You try to lift your foot, and, well, nothing happens. It just hangs there.
Just drags against the bed sheets.
Right, so the bone is completely fixed, but you will wear a brace for the rest of your life just to walk without tripping over your own feet.
It is, honestly, the absolute definition of a surgical nightmare. And it is a chilling reality of operating on the human hip.
Because it's not just bones, right?
No, not at all. Because the hip is the only joint in the human body where you can execute the mechanical procedure with absolute mathematical perfection and still cause a catastrophic life-altering complication.
Because the hip isn't just a ball in a socket. I mean, we tend to think of orthopedics as, carpentry, just bones and screws.
Right, but it's so much more than that.
Yeah, when you look at our sources today, you realize this joint is surrounded by this dense, overlapping, three-dimensional web of high-voltage electrical cables. So, welcome to a new deep dive.
Glad to be here.
Our mission today is to completely map out the hidden landmines of the lower limb and the hip. We are going to decode the exact anatomical doors surgeons use to sneak past these nerves. We're going to figure out why a dying hip can actually trick your brain into thinking you have a bad knee.
That part is always mind-blowing.
It really is. And we are going to break down the literal physics of a limp. But, it all starts with that dropped foot. How does a surgeon doing everything right on the bone end up destroying the nerve?
Well, it happens because you are basically operating in the dark.
Literally.
Not literally, of course, but surgically. When you make an incision, you don't get a textbook view of the anatomy.
Right. It's not color-coded like in the diagrams.
Yeah, exactly. You are looking down a narrow, bloody tunnel. You basically have to develop X-ray vision for the soft tissues.
That sounds terrifying.
It is. Understanding this anatomy isn't just about, memorizing a dry list of muscles for a board exam. It is about spatial awareness.
Knowing where you are in 3D space.
Yes, it's knowing exactly what lies on the other side of the muscle you're about to split blindly with a scalpel.
Okay, so we definitely need a map. And if you're listening right now, whether you are driving or making dinner or sitting at a desk, I want you to use your own body to build this map.
A physical map is the best way to learn this.
Yeah. So reach back and feel the base of your spine, right where your tailbone is. Now take your other hand and find that hard, bony bump on the very outside of your upper thigh.
That's your greater trochanter.
Right. So imagine a single, thick, fleshy cable connecting those 2 points, running deep inside your glutes. According to the text we're analyzing, that muscle is the absolute center of the universe when it comes to the hip, the piriformis.
The Piriformis rule. This is the foundation of everything we're going to discuss today.
It's that important.
Oh, absolutely. If you take nothing else away from this deep dive, take this concept. In the geography of the posterior pelvis, the piriformis is the equator.
The equator, I like that.
Let's trace it carefully. It originates deep inside the bowl of the pelvis, taking its fibers right off the ventral surface of the sacrum, the front side of that tailbone area you just touched.
So it starts on the inside of the pelvis, but it has to get to the outside to attach to that leg bone.
Precisely. And to get out, it has to pass through a massive bony window in the pelvis called the greater sciatic notch.
Okay, a big window.
Right. It reaches through that window and inserts right onto the tip of the greater trochanter. But because this muscle is so thick and because it passes dead center through that notch, it essentially plugs the hole.
Like a cork.
Yeah, exactly. It physically divides the greater sciatic notch into an above doorway and a below doorway.
And this is where the geography gets incredibly high stakes, right? Let's look at the southern hemisphere first. Below the piriformis.
The dangerous neighborhood.
Right. If a surgeon slips below that muscular equator, what are they looking at?
Below the piriformis is where you find the heavy hitters. In the vast majority of human beings, the sciatic nerve, which is the largest nerve in the entire body, exits the pelvis right here.
Wow. Right below that muscle?
Yep. It emerges into the lower medial quadrant of the gluteal region.
Yep.
And, it doesn't travel alone. It is accompanied by the inferior gluteal artery and the inferior gluteal nerve.
The lower medial quadrant. So if you divide the buttock into 4 squares, the bottom inside square is basically the sciatic nerve's living room.
That's exactly right.
So if you put a metal retractor in there and pull, you are stretching the main power line to the leg.
A very dangerous living room.
Yeah.
And that is exactly what causes the foot drop we talked about earlier.
Oh, I see.
Yeah, a poorly placed retractor compressing that nerve below the piriformis.
So that's the southern hemisphere. What about the northern hemisphere? What is above the piriformis?
Above the piriformis, you have the superior gluteal nerve and the superior gluteal artery.
Okay, so superior is above.
Right. They exit the pelvis above this muscular equator, and they immediately run outward, sandwiched right between the gluteus medius and the gluteus minimus muscles.
That's actually pretty convenient naming.
The naming convention here is brilliant in its simplicity. These structures aren't named for where they eventually go. They are named entirely based on their spatial relationship to the piriformis muscle.
So superior means above piriformis.
Yes.
And inferior means below piriformis.
Exactly. The muscle is the absolute reference point.
That is beautifully logical.
Yeah.
But I was reviewing the vascular notes in our stack of sources, and I have to push back on this map a bit.
Oh, okay.
Because there is another massive blood vessel back there. The medial circumflex femoral artery. I mean, isn't that one hidden under a muscle too? I just feel like if I were a surgical resident staring into a bleeding wound, I could easily mistake that artery for something in this above and below piriformis system.
This is what we call the trap.
The trap.
It is a classic anatomical pitfall that catches people constantly. It is incredibly seductive to get those two regions confused because they sound geographically similar if you aren't visualizing the three-dimensional space correctly.
Okay, so how do we untangle them?
Well, the medial circumflex femoral artery is a vital structure. It is the dominant blood supply to the adult femoral head. If you sever it, the blood supply to the hip joint is gone, the bone undergoes a vascular necrosis, and the hip dies.
Which is catastrophic.
Very. But, and this is crucial, it runs deep to a completely different muscle, the quadratus femoris.
The quadratus femoris, not the piriformis.
Deep to the quadratus femoris. The trap is that people conflate the phrase deep to quadratus femoris with the sciatic nerve's pathway below the piriformis.
Oh, I see, because they're both hidden under something.
Right. You have to separate them conceptually in your mind. The medial circumflex is a critical vascular structure hiding beneath the quadratus femoris, way down by the hip joint itself.
Okay.
The sciatic is a massive neural structure emerging below the piriformis, higher up in the pelvis. Mixing up those two landmarks in an exam, or worse, in an operating room, means you don't know where the plumbing is versus where the electrical wiring is.
Separating the plumbing from the wiring. That makes total sense. Okay, while we are back here in the posterior pelvis, there is a specific bony landmark mentioned in the text that seems to act like a toll booth for all this traffic.
The ischial spine.
Yes, the ischial spine. How does that fit into our map?
Well, if the piriformis is the equator, the ischial spine is the prime meridian.
Wow.
Visualize the back of the pelvis again. There's a distinct, sharp, bony prominence sticking out backward and inward. That is the ischial spine.
And it has a ligament attached to it, right?
Exactly. Attached to the tip of it is a very thick fibrous band called the sacrospinous ligament, which runs over to the sacrum. Together, that bony spine and its ligament take the entire massive cutout in the back of the pelvis and divide it into two distinct zones.
So it splits the big hole into two smaller holes.
Right. The greater sciatic notch above the spine and the lesser sciatic notch below it.
And from what I'm reading, the traffic passing through these two notches is drastically different. I mean, the greater notch sounds like a multi-lane highway at rush hour.
Oh, it is incredibly congested. The greater notch contains the piriformis muscle itself, the superior and inferior gluteal vessels and nerves, the massive sciatic nerve trunk, the internal pudendal vessels, the posterior femoral cutaneous nerve.
Just absolutely packed.
It is packed tight with critical structures.
But the lesser notch, that one seems much more exclusive.
Very exclusive. It's essentially a private door.
Woohoo!
The tendon of the obturator internus is the only tendon that uses this lesser door. It passes out of the pelvis through the lesser notch, accompanied by its own nerve.
Wait, I thought the pudendal vessels use it too.
Well, now, the internal pudendal vessels and the pudendal nerve do use it too, but in a very strange way. They actually exit the pelvis through the greater notch, wrap tightly around the outside of the ischial spine, and then dive right back into the pelvis through the lesser notch.
That is bizarre. Like they took the wrong exit on the highway and had to loop back.
Exactly like that.
Yeah.
But functionally, in terms of muscle tendons, the obturator internus owns that lesser notch.
Okay, so to lock this map in before we start making any incisions, the piriformis is the equator.
Check.
The sciatic nerve drops out below it, sitting in the lower medial quadrant.
Yep.
The superior gluteal nerve comes out above it. The medial circumflex femoral artery is a completely separate danger zone, hiding deep to the quadratus femoris.
The plumbing, not the wiring.
Right. And the ischial spine is the toll booth separating the crowded greater notch from the exclusive lesser notch.
That is the mental 3D model you have to carry with you. Because when you actually cut into the skin, you never get to see this beautiful, wide-open textbook picture. You are looking through a tiny window of retracted skin and bleeding fat, trying to orient yourself.
Which brings up the most practical question. If the back of the pelvis is this terrifying minefield of nerves and arteries, how on earth do we actually get inside the hip joint safely to replace it or fix a fracture?
Very carefully.
I bet. The sources detail 4 specific surgical approaches, 4 distinct doors into the hip. And what's fascinating is that every single one of these 4 doors has a very specific hidden danger waiting on the other side.
That's the trade-off. You don't learn surgical approaches just by memorizing a sequence of muscles to move out of the way. You master them by respecting the specific nerve or vessel that you're inherently putting at risk by choosing that specific door.
Let's walk through them then. Let's open door number 1. The anterior approach, historically known as the Smith-Petersen approach.
Okay, the anterior approach. It's brilliant because it comes in straight from the front of the thigh. The surgical interval, the gap the surgeon develops to get down to the joint capsule, lies right between 2 muscles.
The sartorius and the tensor fasciae lata, right, the TFL.
Exactly, the sartorius and the TFL.
Okay, so you find the gap between the sartorius and the TFL and you pry them apart. What is the hidden danger here?
Well, there is a vascular danger and there is a neural danger.
Let's start with vascular.
The vascular danger is heavy bleeding. As you open that gap and look down, you will almost always encounter the ascending branch of the lateral femoral circumflex artery.
Just sitting right there.
It literally bridges right across this muscular gap. If you aren't meticulously dissecting and looking for it, you will tear it with your retractors and it will flood the surgical field with blood.
So you have to tie that artery off before you go deeper.
Yes, you must.
And what about the neural danger?
The neural danger is the lateral femoral cutaneous nerve. It drapes right over the front of this area. If you stretch this nerve or inadvertently cut it during the approach, the patient wakes up with a completely numb anterolateral thigh.
So their thigh goes numb. Do they lose muscle power?
No, it's a purely sensory nerve. It doesn't cause any weakness. Their muscles will work perfectly fine and they won't have a limp. But a massive patch of skin on their thigh will feel dead or have a severe burning sensation, which can be highly distressing for the patient.
A numb thigh. Annoying, definitely distressing, but maybe not a mechanical catastrophe. However, there is a concept regarding this anterior door that completely blew my mind in the readings.
Oh, the internervous plane.
Yes. The sources emphasize that this Smith-Petersen approach is the only approach to the hip that utilizes a true internervous plane. I need you to explain this, but let me see if I can deduce it first.
Go for it.
Okay, so if one muscle is powered by nerve A and the muscle next to it is powered by nerve B, going between them is like cutting exactly along the property line between 2 houses. You can dig a trench right down the property line without ever hitting the electrical line for either house. Is that right?
It is a phenomenal analogy, yes.
Yeah.
You are digging right down the property line.
Okay.
A true internervous plane means the muscles on either side of your incision are on completely different electrical circuits. In the Smith-Petersen approach, the sartorius muscle on the inside is innervated by the femoral nerve.
Got it.
And the tensor fasciae lata on the outside is innervated by the superior gluteal nerve. Because they have different power sources, you can forcefully split the gap between them, pull them far apart, and you will never permanently denervate either muscle.
That's incredible.
It is anatomically free space.
Yeah.
It is the only door to the hip that gives you that incredible luxury.
That is such an elegant design of human anatomy. So that's door 1, the front door. Let's move to door number 2. The anterolateral approach, or the Watson-Jones approach. We are shifting slightly to the side of the hip now.
Yes, shifting to the anterolateral aspect.
Yeah.
The interval for Watson-Jones is between the tensor fasciae lata and the gluteus medius.
The TFL and the gluteus medius. Now, applying the property line logic we just talked about, wait, both of those muscles, the TFL and the gluteus medius, are powered by the superior gluteal nerve. So they share an electrical line. This is not a true internervous plane.
You nailed it. You are separating 2 muscles that share the exact same nerve supply. There's no property line here. You are digging a trench right through a single yard.
All right, so I'm thinking about the dangers of door number 2. We are still somewhat in the front, anterolateral. I'm going to assume that this approach also puts that same sensory nerve, the lateral femoral cutaneous nerve, at risk, just like the first door, because it's in the same neighborhood. Just a numb thigh again.
And that assumption is a massive pitfall.
Oh, really?
It is critically wrong, and it catches so many students off guard. The lateral femoral cutaneous nerve is not the primary catastrophe waiting in this approach.
Okay, what is?
The true danger in the Watson-Jones approach happens deep in the wound, and it's entirely based on how you handle your tools.
How so?
To actually see the hip joint from this angle, surgeons have to apply forceful medial retraction. They have to take a heavy metal retractor, hook it around the anterior structures like the psoas muscle, and pull them forcefully toward the midline of the patient's body.
So they're levering everything inward toward the groin just to get a line of sight into the socket?
Yes, and that inward pull is where the tragedy happens, because sitting right in the front of the hip is the main neurovascular bundle for the leg. And the femoral nerve is the most lateral structure of that bundle.
It's right on the edge.
It sits right on the outside edge, which means when you hook that retractor and pull everything inward, the metal of the retractor crushes directly against the femoral nerve.
Oh, wow. So you aren't cutting the nerve with a scalpel. You are crushing it under the sheer physical pressure of the tool you are using to hold the door open.
Precisely. It causes a severe traction or crush injury to the femoral nerve. And because the femoral nerve is the power source for the quadriceps muscles on the front of the thigh, the result is profound motor weakness.
Not just numbness.
No. The patient wakes up and cannot straighten their knee. Their leg buckles when they try to stand. It is not just a numb patch of skin like the first door. This is a major debilitating motor deficit.
The anterior door risks a numb thigh, but the anterolateral door, if you retract too hard, risks a weak leg. That is a terrifying distinction.
Let's keep moving around the hip to door number 3, the direct lateral approach, also known as the Hardinge approach.
The direct lateral approach is a workhorse, especially for total hip replacements. But it completely abandons the idea of sneaking between muscles.
No more intervals. Nope, it doesn't look for an interval. It goes straight through the wall. The method here is to physically take a scalpel and split the gluteus medius muscle right down its center.
You just chop the muscle in half. Obviously, there's no internervous plane there. What is the hidden danger of just splitting the muscle like that?
The danger is altitude. It is all about how far up the hip you carry that split. Remember our map from the beginning?
The equator map.
Right. The superior gluteal nerve emerges above the piriformis and runs straight into the gluteus medius to power it. If the surgeon's split is carried too far proximally, meaning too high up toward the pelvis, the scalpel will cross right through the path of the superior gluteal nerve and sever it.
And the sources give a very strict, unforgiving measurement for this, like a hard limit.
It is a critical number. The strict danger zone is 5 centimeters above the tip of the greater trochanter. I'm going to repeat that because it is vital for spatial awareness. 5 centimeters above the tip of the greater trochanter.
5 centimeters, 5 centimeters.
If your muscle split goes higher than that 5 centimeter limit, you cut the nerve.
And the consequence of cutting it.
You instantly denervate the abductor muscles. The gluteus medius and minimus die.
So they can't stabilize.
Exactly. The patient permanently loses the ability to stabilize their pelvis when they stand on that leg. They're left with a severe, lurching limp that can never be fixed, all because the incision drifted 1.5 inches too high.
5 centimeters. 5 centimeters above the greater trochanter. That is an incredibly tiny margin for error when you consider the size of a human hip. Which brings us to the final main door, door number 4, the posterior approach, or kosher Langenbeck.
This is the most common approach for treating trauma, like fixing fractures of the acetabulum, the socket itself. To get in from the back, you have to bypass the largest muscle in the region. You split the massive gluteus maximus muscle.
Again, no internervous plane.
No, you just spread the muscle fibers apart.
And based on the map we built earlier, I know exactly what monster is waiting in the dark back there. The sciatic nerve.
You are right back in the sciatic nerve's living room. As soon as you split the gluteus maximus, the sciatic nerve is sitting right there in the lower quadrant.
So if you aren't careful...
If your dissection is sloppy, or if an assistant pulls a retractor too aggressively against the nerve, you injure it. And that leads to the dreaded complication we used to open this discussion, the foot drop.
Because it's sensitive.
Very. The peroneal division of the sciatic nerve is incredibly sensitive to stretch. Injure it here, and the patient loses the ability to lift their foot at the ankle.
The stakes are just astronomically high. Oh, before we leave the surgical doors, the text did mention a bonus door, an anteromedial approach called the Ludloff approach.
The anteromedial approach is highly specialized. You rarely see it in adult trauma. It is primarily used in pediatric orthopedics, specifically to release tight structures in developmental dysplasia of the hip.
Okay, and the risk.
You are coming in from the inner thigh right through the groin, and the structure at imminent risk in that inner compartment is the obturator nerve.
Which is the most perfect transition we could ask for, because mentioning the obturator nerve leads us right into one of the most bizarre and fascinating phenomena in human anatomy that we came across in this deep dive.
Ah, yeah.
I like to call it the liar's joint. We need to talk about exactly why a dying arthritic hip can disguise itself as a bad knee.
This is a diagnostic trap that catches incredibly smart, experienced clinicians every single day. And the primary culprit is the obturator nerve. Let's map its origins first.
Okay, where does it come from?
The obturator nerve arises from the spinal roots in the lower back, L2, L3, and L4. Again, that is L2, L3, L4.
Let me say that back to make sure I have it locked in. L2, L3, L4.
Correct. It travels deep through the pelvis, and it enters the inner thigh through a small bony tunnel called the obturator canal.
And what does it do?
Its main job in life is to supply sensation to the skin of the medial thigh, the inner thigh, and to power the massive adductor muscles that allow you to squeeze your legs together.
Sounds straightforward.
But crucially, as it travels down the leg, it sends out articular branches. These are tiny sensory wires that plug into the joint capsules to relay pain signals. And the obturator nerve sends these wires to both the hip joint and the knee joint.
So it's basically a party line. You have one telephone wire connecting two completely different houses, the hip house and the knee house back to the same exchange in the brain.
That is the perfect way to visualize it.
Mm-hmm.
And that shared electrical wiring creates a massive clinical blind spot.
Let's walk through the clinical scenario provided in our sources, because this brings the anatomy to life in a really frustrating way. Imagine a 69-year-old patient who walks into a clinic.
Okay.
They are complaining of intense grinding pain on the inside of their knee. Naturally, the doctor focuses on the knee. They take an x-ray.
Makes sense.
The x-ray shows some minor wear and tear, a little bit of joint space narrowing, maybe a small bone spur, which is holding normal arthritis for a 69-year-old. So the doctor treats the knee, of course. The patient gets cortisone injections right into the knee joint. They spend weeks going to physical therapy to strengthen the knee. Maybe the pain gets so bad the surgeon even goes in with a camera, does an arthroscopy, and cleans out the knee. But after all of that, the pain never leaves. It doesn't get even a fraction better.
And it never will get better, because the pain was never in the knee to begin with.
Which is just mind-blowing. Where was the pain originating?
It was radiating from the hip. If a clinician had simply taken 30 seconds to stop looking at the knee, put their hands on the patient, and examine the hip, they would have found severe pathology.
Like what?
They would have found a hip joint with a fixed flexion deformity, meaning the hip is permanently stuck in a slightly bent position, and they would find severely restricted internal rotation.
So the hip is actually destroyed.
Yes, the patient's actual hip joint is destroyed. It is bone on bone, deeply arthritic, and it is screaming in agony. But because of that shared party line, the obturator nerve picks up the distress signal at the hip, sends it up to the brain, and the brain misinterprets the origin of the signal. The brain physically feels the pain in the knee.
That is tragic. You could spend a whole year, thousands of dollars, and undergo unnecessary surgery, getting treatments for a knee that is perfectly fine, all because of a bad wire.
Exactly.
Now let's dive even deeper into the anatomy of this. The obturator nerve is large and has many branches. Which exact branch is responsible for carrying this phantom knee pain?
It is highly specific. The referred pain travels via the continuation of the nerve branch that supplies the adductor magnus muscle.
The adductor magnus. Out of all the muscles in the inner thigh, why that one specifically?
Think about the physical layout of the inner thigh muscles. The adductor magnus is exactly what its name implies. It is massive.
Big muscle.
And it reaches the absolute furthest down the thigh bone. It originates up by the pelvis and attaches all the way down at a bony bump called the adductor tubercle, which is located right on the medial side of the knee joint itself.
Oh, wow. So it goes all the way to the knee.
Right. Because the muscle fibers reach the furthest down the leg, its nerve branch has to travel the furthest down the leg to power it, bringing that nerve right into contact with the capsule of the knee joint.
Okay, I have to challenge this because I was staring at a nerve map while prepping for this deep dive, and there is another nerve that seems like a much better suspect.
Let's hear it.
What about the saphenous nerve? The saphenous nerve runs right down the inside of the leg, and its whole job is to supply the medial knee. Why couldn't this referred pain just be traveling along the saphenous nerve?
It is an excellent question, and it is exactly the distractor that examiners love to use to trick medical students on exams.
Ah, I fell for it.
Well, geographically, it makes sense. It is true that the saphenous nerve, which is actually a terminal branch of the femoral nerve, not the obturator, supplies the medial side of the knee.
Hmm.
But here is the critical physiological difference.
Okay.
The saphenous nerve only supplies the skin. It is purely a cutaneous nerve.
Oh.
Yeah. In order to transmit deep referred joint pain from the hip to the knee, the nerve in question must physically send articular branches into the deep joint capsules of both joints. The saphenous nerve doesn't touch the deep capsule of the hip. Only the obturator nerve plugs its wires into the hinges of both the hip and the knee.
That distinction makes complete sense. The saphenous nerve is just a surface alarm system for the skin, but the obturator is wired deep into the structural hinges of the body. So L2, L3, L4, the obturator nerve is the ultimate liar's nerve.
It absolutely is, and it leads to a golden, unbreakable rule for anyone practicing musculoskeletal medicine. If a patient walks into your office complaining of knee pain, you must, without exception, examine their hip.
So we've covered how hip pathology can cause agonizing pain and how it can lie about where that pain is. But what does this all mean for how we actually move? How does a problem in the hip cause mechanical failure of the body?
Ah, biomechanics.
Right. That brings us to the actual biomechanics of walking and a very famous clinical finding, the Trendelenburg sign.
The Trendelenburg sign is one of the most elegant and brutally honest physical exams in medicine because it relies on pure vector physics.
Okay, break that down for me.
When you are walking, every time you lift one foot off the ground to take a step, you are standing on one leg. At that exact moment, the sheer weight of your torso and gravity want to pull the unsupported side of your pelvis, the side with the foot in the air crashing down toward the floor.
Right, because you lose your structural support on that side.
Exactly. The only thing stopping you from toppling over sideways is a massive contraction of the abductor muscles, primarily the gluteus medius on the side of the leg you are standing on.
They act like a counterweight.
They fire, pulling the pelvis down toward the femur on the standing side, which acts as a counterbalance to keep your pelvis perfectly level. When this biological counterbalance system fails, the pelvis visibly drops on the unsupported side. That pelvic drop is a positive Trendelenburg sign.
But the sources make a really interesting point that this isn't just about a muscle being weak. It is an entire interconnected mechanical system. The texts call it the abductor lever arm.
It is a perfect mechanical lever. For this lever to function and keep you upright, you need three completely intact components. It is exactly like a playground seesaw.
Okay, a seesaw.
First, you need a healthy working muscle to physically pull the lever. Second, you need an intact working nerve to carry the electrical signal telling the muscle to pull.
So muscle and nerve, what's the third?
Third, you need intact geometric physics, meaning the physical bony architecture, the relationship between the femoral head sitting in the socket, the angle of the femoral neck, and the position of the greater trochanter has to be solid and properly angled to act as a fulcrum.
Oh, I see.
If any one of those three components, muscle, nerve, or bone geometry breaks, the lever fails, the seesaw tips, and you limp.
Let's do an in-depth analysis of those failures because the text provides some really clear examples. Give me an example of the geometry breaking, the fulcrum failing.
A classic geometric break is congenital hip dislocation.
Okay.
The child is born with the femoral head literally sitting outside of the socket. The fulcrum of your seesaw is entirely missing, floating in space, so no matter how hard the muscle pulls, the lever can't generate any counterbalancing force.
What's another one?
Another geometric failure is a condition called coxavara. Normally, the neck of the femur sits at about a 135-degree angle to the shaft. In coxavara, that angle is severely decreased, maybe to 90 degrees.
So it's squished down.
Right. That physically shortens the horizontal distance of the lever arm. The muscle is pulling, but it has lost its leverage, so it can't overcome body weight. Or consider a non-union of a femoral neck fracture. The bone is literally broken in half and hasn't healed. The muscle pulls on the trochanter, but the force can't transmit across the broken bone to the socket. The lever is disconnected.
Okay, so those are structural bone failures. What about the muscle component breaking?
That would be something biological affecting the tissue itself, like infantile paralysis, polio, specifically affecting the gluteal muscles.
Oh, I see.
The bone geometry might be perfectly fine, and the nerve might even be trying to send a signal, but the muscle tissue itself is destroyed, atrophied, and physically cannot contract to pull the seesaw.
And a nerve break. The electrical failure.
We actually covered the most common iatrogenic, meaning surgeon-caused nerve break, earlier, a superior gluteal nerve palsy, tying right back to door number 3, the Hardinge approach.
Ah, the 5 centimeters rule.
Yes. If you carry that surgical split more than 5 centimeters above the greater trochanter, you sever the nerve. The muscle is completely healthy, the bone is perfectly aligned, but the wire is cut. The signal never arrives. The lever fails, and the patient drops their pelvis with every single step.
Okay, here is where I get a bit stuck, and I want to bring an analogy to test this. What about tuberculous arthritis of the hip? TB of the hip.
Okay, interesting.
That is a horrifying, deeply destructive disease that causes immense joint-destroying pain. Surely, if a patient has tuberculosis eating away at the cartilage in their hip joint, they're going to limp. Why wouldn't that massive destruction cause a positive Trendelenburg sign?
This is the crucial distinction between biology and mechanics. Yes, a patient with tuberculous arthritis of the hip will absolutely limp. They will limp severely, but they're limping for a completely different reason: to avoid pain.
To avoid pain.
We call that an antalgic gait. Antalgic literally means against pain. When they step on the bad leg, the destroyed joint surfaces grind together. It sends a spike of agony to the brain, and they immediately rush to get their weight off that leg and onto the good leg. They spend as little time as possible in the stance phase.
So it's a behavioral limp. The body is modifying its movement to survive the pain, not because a mechanical part is broken.
Exactly. A true Trendelenburg sign is a silent mechanical lever failure. TB of the hip destroys the cartilage, it causes severe inflammation, and it hurts terribly.
But it doesn't break the seesaw.
But, and this is the key to the biomechanics, it does not fundamentally break the geometry of the lever arm, it doesn't detach the muscle from the bone, and it doesn't denervate the muscle. It is biological destruction of the joint surface, not a mechanical disconnection of the lever system.
So going back to the playground seesaw, TB of the hip is like taking the seesaw and wrapping it in rusted barbed wire. You definitely don't want to use it, and you'll jump off it as fast as you can because it hurts, but the wooden plank itself isn't actually broken in half. The lever is intact. It's just painful.
That is exactly right. The seesaw is covered in barbed wire, but it's not broken in half. That perfectly separates the antalgic pain limp from the true Trendelenburg liver failure.
It's amazing how much physics dictates human movement. Let's shift gears and look at another massive nerve issue. We've seen how cutting the superior gluteal nerve drops the pelvis.
Right.
Now, let's return to the massive sciatic nerve and that devastating foot drop we teased at the very beginning of the show. How does a surgeon playing detective figure out exactly where the nerve is damaged? Is it broken up high in the hip or down low by the knee? This brings us to a concept I want to call the switch muscle.
This is one of my favorite anatomical quirks because it requires you to rethink what you are looking at. To play detective here, you first have to realize that the sciatic nerve, as we picture it, is actually a massive anatomical deception.
A deception? How so?
When you dissect a cadaver and look at the sciatic nerve in the back of the thigh, it looks like one gigantic thick yellow cable. But it's lying to you.
It's lying.
It is actually two completely distinct, separate nerves, the tibial division and the peroneal division, that are merely traveling together, wrapped tightly inside one single outer sheath.
Oh, wow.
They don't actually mix their internal fibers. They just ride the same subway car down the thigh for convenience, and then they physically unzip and separate from each other at the upper popliteal fossa, right in the back of the knee.
I love this. It's literally two nerves in a trench coat pretending to be one big nerve.
Two nerves in a trench coat. And because they're functionally separate, they do different jobs. Here is the golden rule that lets a clinician play detective. Every single hamstring muscle on the back of your thigh is supplied by the tibial division of that nerve.
Okay, all the hamstrings.
The semitendinosus, the semimembranosus, the long head of the biceps femoris, every single one, with exactly one bizarre exception.
And what is the exception? What is the switch?
The short head of the biceps femoris.
The short head.
It is a smaller muscle tucked on the inside of the back of the thigh. It is the only hamstring muscle supplied by the peroneal division. And critically, for our detective work, it receives this nerve supply high up in the thigh long before the two divisions actually split apart behind the knee.
Okay, this is the switch. Let's play this out with an illustrative scenario. Let's say a patient is brought into the emergency room after a severe trauma, maybe a high-speed car crash. Their leg is a mess, and they have a foot drop. They cannot lift their foot upward. We know that lifting the foot is the job of the peroneal nerve, so we know the peroneal division has failed.
Right, that much is clear.
But how do you, as the consulting doctor, know if the nerve was stretched and injured high up in the hip where the whole sciatic trunk is, or if it was injured way down by the knee where the peroneal nerve wraps around the bone?
You test the switch. You examine the short head of the biceps femoris.
How does that work?
If you ask the patient to flex their knee against resistance, and you palpate that muscle, and the short head of the biceps femoris is dead, it's flaccid, denervated, and won't contract, then you know the electrical signal was cut off before it ever reached that muscle.
Which means?
Which means the injury must be high up in the thigh or the hip at the level of the main sciatic trunk. The injury happened before the nerve even had a chance to branch off to power that thigh muscle.
Okay, but what if you examine them and the short head is functioning normally? The muscle fires, but the foot is still dropped.
If the short head is working perfectly, but the foot is dropped, then the peroneal nerve must have been injured after it successfully delivered the power signal to the thigh.
Oh, because the thigh got the signal.
Exactly. Which means the injury has to be lower down the leg. It almost always localizes to the common peroneal nerve right where it wraps superficially around the fibular neck, just below the knee on the outside of the leg.
That is incredibly elegant. The short head of the biceps femoris is the single muscle that flips the switch to tell you where the invisible damage is hidden. But why does this actually matter in real life? Does knowing the location change how a surgeon treats it?
It changes everything about the surgical plan.
How so?
Operating on a nerve that is wrapped superficially around the fibular neck just below the skin is a relatively straightforward, low-risk procedure. You make a small incision, you're right there.
Okay, easy enough.
But trying to surgically explore the main trunk of the sciatic nerve deep in the meat of the upper thigh, underneath massive layers of muscle and near major blood vessels, is a complex, bloody, and highly morbid procedure. You do not want to go digging in the deep thigh unless you are absolutely 100% certain the nerve lesion is located there.
Let's talk about timing. If a nerve is actually transected, like physically cut in half by a sharp piece of fractured bone, is there a ticking clock on sewing it back together?
Yes, there is a very strict timeline based on nerve physiology. If a nerve is transected, the optimal window for a definitive surgical repair is 1 to 3 weeks. 1 to 3 weeks.
Wait, 1 to 3 weeks? Why wait at all? If the power cord is cut, why not sew it back together the minute they hit the trauma bay on day 1?
Because of a process called Wallerian degeneration and the zone of injury.
Zone of injury.
When a nerve is violently stretched or torn by trauma, the damage isn't just at the exact millimeter where it snapped. The nerve ends on both sides are severely traumatized, stretched, and bruised for centimeters in either direction.
Oh, I hadn't thought of that.
If you try to sew those ragged ends together on day 1, the tissue is still dying. Microscopic cell death is occurring. The delicate nerve tubes won't line up, the scar tissue will block regeneration, and the repair will fail.
So the damage is still spreading even after the accident is over?
Exactly. You have to wait 1 to 3 weeks to allow the bruised tissue to fully declare itself. You let the dying tissue die off. Then when the surgeon goes in at week 2, they can clearly see the line between dead scar tissue and healthy, viable nerve fibers. They meticulously trim back the nerve ends until they hit healthy tissue, and then they suture those pristine ends together.
1 to 3 weeks, 1 to 3 weeks. You have to let the dust settle before you rebuild. You know, we were talking about scar tissue and trauma. It reminds me of a scar story I heard during my rotations.
Oh, let's hear it.
I remember seeing a patient with a massive surgical scar running down the back and outside of their knee. They had suffered a knee dislocation years prior. Now, there is a specific trap mentioned in our sources about peroneal nerve injuries at the knee. People naturally assume that if you dislocate your knee forwards, an anterior knee dislocation, where the shin bone shifts violently in front of the thigh bone, you will tear that peroneal nerve.
And that assumption is factually incorrect.
Yeah.
It's a common distractor in board exams.
Right.
Visualize the anatomy again. The common peroneal nerve sits at the back and the far outside of the knee. Therefore, to stretch and tear that specific nerve, the knee has to blow out backward and outward.
Oh, because it's in the back.
Yes. Peroneal nerve injuries are almost exclusively associated with posterolateral corner disruptions of the knee.
So what does an anterior dislocation threaten?
Anterior dislocations, where the bone shifts forward, mostly threaten the massive popliteal artery running right down the center of the back of the knee, not the nerve on the outside.
That makes spatial sense. Anterior threatens the artery, posterolateral threatens the nerve.
Okay, we've explored catastrophic, life-altering nerve cuts and major traumas. Let's pivot and look at something entirely different.
This is good.
Let's look at the repetitive mechanical stress that athletes face. And this actually brings us full circle right back to the tissues surrounding the piriformis and the greater trochanter.
The biomechanics of sports are endlessly fascinating because athletes push the human body to extremes, exposing structural friction points that normal everyday walking never would.
Let's run another clinical scenario to puzzle this out. We have a 23-year-old semi-professional ballet dancer who comes into your clinic.
Okay, dancer.
She is complaining of a sharp, snapping lateral hip pain right on the hard outside bump of her hip, and she says it only happens when she is dancing and doing high leg extensions. Now, my immediate guess, just hearing a patient say lateral hip pain over the greater trochanter, is trochanteric bursitis. The fluid sac over the bone is inflamed. And if she were a sedentary 65-year-old who just started walking for exercise, you'd probably be right. Trochanteric bursitis is very common.
But she's 23.
Right. But because she's a 23-year-old ballet dancer, your diagnosis is almost certainly incomplete or wrong. The correct diagnosis here is external coccyx saltans, more commonly known as the external snapping hip.
The external snapping hip. What exactly is snapping? I'm picturing a bone clicking in and out of place.
The clue to understanding the mechanism is the specific sport. Ballet involves extreme, repetitive flexion, extension, and rotation of the hip joint.
So a lot of movement.
When you perform those movements thousands of times a week, the thick, fibrous band of tissue running down the side of your leg, the iliotibial band or IT band, becomes incredibly tight. Specifically, it thickens at its posterior edge.
Okay, it gets thick.
Alternatively, the anterior edge of the gluteus maximus muscle, which feeds into that band, can also thicken. Either way, as the dancer flexes her hip forward and extends it backward, that thick, taut band violently snaps back and forth right over the bony prominence of the greater trochanter.
So it's just rubbing over the bone?
It literally twangs like a thick rubber band being pulled tightly over a rock.
Ouch! You can almost hear it snapping. That sounds incredibly painful and disruptive. How do you treat that? You can't just tell a professional dancer to stop moving her leg.
You certainly can't. We use a stepwise treatment ladder. You always start conservative. First, aggressive physical therapy focused on intensely stretching the IT band and stabilizing the core and pelvis to change her biomechanics.
And if that doesn't work?
If that fails, and she is still in pain, you step up to a localized steroid injection directly into the bursa beneath the snapping band. This shuts down the acute, localized inflammation caused by the friction.
And if he goes back to the studio and a month later she's still snapping like a rubber band despite the steroid?
Then you have exhausted conservative measures and you move to the final rung of the ladder.
Yeah.
Surgery. Specifically, a procedure called a Z-plasty lengthening of the iliotibial band.
A Z-plasty. What does that actually mean mechanically?
The surgeon makes a literal Z-shaped cut into the tight fascial tissue of the band. By cutting it in a Z pattern and then sliding the flaps past each other before suturing them back together, you physically elongate the band.
Oh, I see. You're making it longer.
You add length to the tissue, relieving the extreme tension so it no longer snaps tightly over the bone during movement.
That is brilliant geometry applied to surgery. So that's the external snapping hip happening on the outside of the thigh. Are there other types? The sources mention a broader context here.
Yes, there are 3 distinct types of snapping hips, and they present very differently based on their anatomy. The external one we just discussed causes pain on the outside, the lateral aspect.
Okay, what's next?
Then there is the internal snapping hip. This happens deeper inside. The iliopsoas tendon, which is your main powerful hip flexor, muscle snaps abruptly over a bony ridge at the front of the pelvis called the iliopectineal eminence.
And where does that hurt?
Because of its location, an internal snapping hip presents as deep groin pain, not lateral pain.
And the third type?
The third is intra-articular, meaning the mechanical problem is happening inside the actual sealed hip socket itself. This isn't a tendon snapping over a bone. This could be a torn piece of cartilage, a labral tear, or a loose fragment of broken bone physically floating around inside the joint fluid.
So it's inside the actual joint.
Exactly. This type doesn't just make a snapping sound, it causes mechanical locking or catching. The patient will say their hip suddenly freezes up. It feels like a gear grinding to a halt. Because the pathology is deep inside the bone, this type absolutely requires advanced imaging like an MRI arthrogram to diagnose properly.
Lateral pain for external, groin pain for internal, and deep catching for intra-articular. That's a great way to separate them clinically. Now, staying with this theme of soft tissue hip issues causing severe pain, let's talk about piriformis syndrome.
Piriformis syndrome.
And more importantly, let's talk about the dangerous, confusing world of medical eponyms, diseases, and tests named after old doctors.
Piriformis syndrome brings us right back to our starting map. It occurs when that equator muscle, the piriformis, severely spasms, tightens, or hypertrophies, and it physically compresses the sciatic nerve right where it exits the pelvis below the muscle.
Oh, it's pinching the nerve.
Yes. Because it is squeezing the sciatic nerve, it mimics the exact same shooting, radiating leg pain as a herniated disc in the spine. It looks exactly like sciatica, but the problem is in the buttock, not the back.
And there is a very specific physical exam maneuver to reproduce this pain and prove it's the piriformis, right?
Yes. To isolate and test for piriformis syndrome, the clinician performs forced internal rotation of a flexed hip.
How do you do that?
By bending the hip up and forcefully twisting the leg inward, you put maximal stretch on the piriformis muscle. If the muscle is inflamed, this stretch forces it to squeeze down hard on the sciatic nerve, reproducing the patient's exact shooting pain.
And the eponym, the old doctor's name, for this specific test.
This specific maneuver is known as Pace's sign.
Pace's sign. Now, the sources give a very specific warning here about getting trapped by other famous signs.
The trap of eponyms. Medicine is absolutely full of them. Every doctor in the 19th century wanted something named after them.
That's so true.
And it is terribly easy to mix them up under pressure, especially on exams. Pace's sign is for piriformis syndrome, though it's worth noting it belongs to a whole family of piriformis tests, including the Freiberg test and the Ferrer maneuver.
But people get them mixed up.
Oh, examiners love to take completely unrelated eponyms and throw them into multiple choice questions to see if you actually understand the anatomy or if you are just guessing at names.
All right, let's do a lightning round beat. I'm going to throw out the eponyms mentioned in the sources, and I want you to tell me what they actually test for so our listeners don't fall for the trap.
I'm ready. Let's do it.
Number 1, Wilson's sign.
If you see Wilson's sign on a hip exam, ignore it. It has nothing to do with the hip. Wilson's sign indicates osteochondritis dissecans of the knee, a specific problem where a piece of bone and cartilage loses its blood supply and loosens in the knee joint.
Number 2, McMurray's sign.
Very famous, but again, wrong joint. McMurray's is the classic clicking test for a torn meniscus in the knee.
Number 3, Pellegrini stata.
Pellegrini stata isn't even a physical test. It is a radiological sign. It refers to chronic calcification of the medial collateral ligament, the MCL, in the knee following an old tear. You will see a little white flake of bone on the x-rays sitting just off the side of the knee.
And finally, number 4, which I find completely hilarious to even be on this list, Hoffman's sign.
Hoffman's is completely out of left field. That is a neurological sign indicating upper motor neuron damage, specifically cervical stenosis, severe compression of the spinal cord in the neck.
In the neck.
Yes. The test involves flicking the patient's middle finger and watching to see if their thumb twitches in response. It has absolutely, categorically nothing to do with the hip or the lower limb.
It's just absurd. Flicking a finger to test a neck problem thrown into a multiple choice question about a hip pathology, they really just want to see if you're panicking and guessing.
They do.
Okay, we are rounding the corner into our final major topic of this deep dive. We've spent this entire time talking about how to navigate around the limb, how to fix the bone, how to preserve the nerves, and how to balance the levers.
Right, preservation.
But what happens when the limb simply cannot be saved? Whether it's due to massive crushing trauma, an aggressive bone tumor like an osteosarcoma, or severe vascular disease where the tissue is dead, sometimes surgeons must amputate.
It's a sad reality.
But the sources make a deeply profound point. Amputation isn't just about removal. It is a highly complex exercise in metabolic economics and tissue engineering.
That is exactly what it is, and it is a heavy responsibility. The moment you remove a part of the lower limb, you permanently, irrevocably alter the energy budget of that patient's body for the rest of their life.
Because it's harder to walk.
Human walking with biological legs is incredibly efficient. Walking with a prosthetic limb, even the most advanced carbon fiber prosthesis, is significantly less efficient. It demands more oxygen, more heartbeats, more raw energy.
Let's look at the hard numbers. How much extra energy does it take to walk after an amputation?
The baseline metric everyone needs to know, the standard of comparison, is for a transtibial amputation, which is a below-the-knee amputation. Walking with a well-fitted, standard below-knee amputation requires roughly 25% extra energy expenditure above the patient's normal pre-amputation baseline walking.
25% extra energy, so it takes a quarter more effort just to walk from the couch to the mailbox or to push a grocery cart down the aisle.
Exactly. 25% extra energy. 25%. And that is just the baseline. That number only goes up the higher up the leg you cut. The core principles of amputation economics are twofold.
What's the first?
First, the metabolic cost of walking increases dramatically.
Yeah.
The more proximal, the higher up the amputation level is.
Huh.
A transfemoral, or above-knee amputation, doesn't just double the energy, it can require 60% or 70% more energy.
Wow, 70%.
Yes, some older patients with vascular disease simply cannot generate that much energy, and they become permanently wheelchair-bound.
And the second principle of the economics.
The energy cost is inversely proportional to the length of the residual limb and the number of functional joints preserved. Every single biological joint you manage to keep, especially the knee, and every single centimeter of healthy bone you can preserve in the stump is essentially metabolic energy saved in the bank for the rest of that patient's life.
So keeping the knee is huge.
A longer lever arm in the prosthesis means less work for the hip muscles. If you can save the knee, you save their energy.
That is a staggering weight on the surgeon's shoulders. You are literally budgeting their lifetime exhaustion levels while you are in the operating room. But what happens if you can't save anything? What if you have a massive tumor that involves the pelvis itself and you have to move to the absolute top of the limb?
You are describing the most extreme radical procedure in lower limb orthopedics. A hindquarter amputation, clinically known as a hemipelvectomy.
A hemipelvectomy.
You aren't just removing the leg, you're removing the entire leg and half of the pelvis bone. You have to physically disarticulate the pelvis by cutting through the symphysis pubis in the front and sawing through the sacroiliac joint in the back near the spine.
That leaves an enormous gaping defect in the body. You are exposing the abdominal contents. How on earth do you close a wound that size? Where does the skin and muscle come from to cover that hole?
This is where surgical tissue engineering and flap planning become paramount. You have to borrow tissue from somewhere else. The standard, most reliable method to cover a hemipelvectomy defect is to use a posterior gluteal flap.
What does that involve?
You basically dissect out the massive gluteus maximus muscle from the buttock, keeping its blood supply attached, and you use it like a giant blanket. It is the largest, thickest, best vascularized tissue option available. You fold it forward over the defect to protect the internal organs and pad the exposed bone.
But wait, if they are doing this radical surgery to remove a massive tumor, what if the tumor is in the buttock itself? You can't use the gluteus maximus as a blanket then because you have to cut it all out to get rid of the cancer.
That is the ultimate surgical variant, and it requires incredible foresight. If the tumor is in the posterior buttock, the standard posterior flap is impossible. It's gone.
So what do you do?
In that scenario, surgeons must completely flip the script. They have to create an anterior flap. They harvest the skin, fat, and muscle from the front of the thigh, and they must meticulously preserve the superficial femoral artery to keep that massive flap alive.
So you're basically taking the front of the leg, keeping its main blood vessel attached, and folding it backward over the pelvis to cover the hole.
Exactly. You are folding the front to the back. And the overarching philosophy here is profound. When planning a massive amputation for cancer, the surgeon doesn't just look at the MRI and decide where to cut based on where the tumor ends.
They don't?
No, you must plan the entire massive amputation backward, based entirely on which specific blood vessel will survive the tumor resection. If the tumor involves the gluteal artery, the posterior flap is dead before you even start the surgery, and you must rely on the anterior femoral artery.
That is incredible planning.
The blood supply dictates the architecture of the survivor.
The blood supply dictates the architecture. That is an incredible phrase, and it perfectly encapsulates the stakes of this anatomy. Okay, we have covered a staggering amount of ground today. Let's do our recap block of this journey. We started at the piriformis, the muscular equator of the buttock, mapping the danger of the sciatic nerve below and the superior gluteal nerve above, and separating the plumbing from the wiring.
Right, and then we opened the 4 surgical doors, realizing that the anterior Smith-Petersen gives you a true internervous plane, but risks a numb thigh, while hard medial retraction on the anterolateral Watson-Jones crushes the femoral nerve and weakens the whole leg.
We untangled the Liers joint, discovering how the L2, L3, L4 obturator nerve sends a party line to both joints, tricking the brain into thinking a destroyed arthritic hip is actually a sore knee. We measured the precise physics of a limp, learning that the Trendelenburg seesaw only fails when the geometric lever breaks or the nerve is cut, not just when it hurts like in TB.
We located hidden nerve damage using the short head of the biceps femoris as our peroneal switch, and learned why we must wait 1 to 3 weeks for the zone of injury to declare itself before repairing a cut nerve.
We explored the snapping hips of ballet dancers and laughed at the absurdity of flicking a finger for a hip exam. And finally, we calculated the lifelong metabolic cost of losing the limb 25% extra energy for a below-knee cut, and how surgeons fold thigh muscles like vascularized origami to close a hemipelvectomy.
It is a profound testament to how interconnected, delicate, and utterly unforgiving the anatomy of the hip and lower limb truly is.
But before we wrap up this deep dive, I want to leave you with one final provocative thought. The one-liner that really chilled me from the readings. We've talked extensively today about preserving the hip joint.
We have.
But what if a surgeon has to intentionally destroy it to save the patient? What if they have to perform an arthrodesis, a permanent fusion of the hip joint bones, into one solid, immovable block?
It is a rare salvage procedure today, usually done for severe, untreatable bone infections or massive, unfixable trauma in young, heavy laborers who need absolute stability. And it carries a massive anatomical trap of its own.
Right. The sources note that almost instinctively, surgeons who don't specialize in this specific fusion tend to fuse the hip in an abducted position, meaning they fuse the leg bone slightly swung out away from the midline of the body. Visually, in the operating room, it looks like it would give the patient a wider, more stable stance for walking, but our sources state unequivocally that this is a catastrophic anatomical error.
It is a devastating mistake that ruins the rest of the patient's life.
Why is it so bad?
If you fuse the hip in abduction, the leg is rigidly locked, pointing outward. When that patient gets out of bed, tries to stand up straight, and put both feet flat on the ground, their pelvis has to tilt severely sideways just to accommodate that locked, angled leg.
Pelvis tilts.
And when the pelvis tilts permanently, the spine, which sits on top of the pelvis, has to curve entirely out of alignment just to keep the patient's head level and their eyes looking straight ahead.
You are forcing the spine to bend and compensate for the rigidly locked hip.
For every single hour of every single day for the rest of the patient's life. By fusing the hip abducted, you practically guarantee that the patient will suffer 25 years of agonizing, crippling back pain. You solve the hip problem by completely destroying the mechanics of the spine. It is a stark, terrifying testament to how one single degree of angle in the hip literally dictates the mechanical fate of the entire human body.
One wrong angle, 25 years of pain. It really brings back to the horror story we started with, doesn't it? The x-ray might look clean, the bone might look solid. You might have executed the technical carpentry steps flawlessly, but if you don't deeply understand the hidden network, the invisible nerves, the physics of the levers, the angles of the joints, you can leave the patient permanently unable to lift their foot or doomed to decades of back pain.
The anatomy doesn't care about your good intentions in the operating room. It only cares about execution.
Which is why I highly encourage you, as soon as you finish listening, to take a blank page and physically draw that piriformis map on your own. Draw the sacrum, draw the equator, draw the sciatic nerve below and the superior gluteal above. Cement that complex 3D geography in your mind so you never step on those hidden landmines. Next time, we'll be diving into the microscopic warfare of the immune system and the hidden mechanisms of autoimmune disease. Thank you so much for joining us on this deep dive. Until next time, keep mapping the unknown.